Hey everyone, it's Dr. Sorin here, and I am super excited to have my good friend, Dr. Ramon Issa, on the show today. We are going to be talking about some really exciting topics. We're going to be talking about reviewing the study that was used to give the emergency use authorization for the Pfizer COVID vaccine. Got some really interesting info Dr. Issa has found reading through that study. And also going to be talking about some of the flu rates. The flu has been cured, at least according to the CDC statistics. We've seen a drastic reduction in flu cases. So you want to definitely stay tuned for that. And we're going to look at some CDC data of COVID numbers. So a lot of good stuff. So definitely want to stay tuned for that. Also, we're going to be streaming this on YouTube. So I'm going to be showing some screenshots. So definitely check out the Dr. Sorin show, DrSorin show on YouTube. Definitely want to see it there to get links to the some of the pages I'm going to show and links to some of that info. Dr. Issa, thank you so much for joining me.
And thanks for having me, Sorin. It's great to be here.
Yes. And I always love having you on, man. You're one of the smartest guys I know. So just for everybody to know, go ahead and give your credentials. You and I went to medical school together.
Right. I'm a medical doctor, MD, have almost 20 years experience. And I have some experience in the family practice world, in the clinic, in the urgent care, and in emergency rooms as well.
That's right. So you're board certified family practice. You've done ER basically for 20 years, and you're currently working in Northern Idaho, living in the Northern Idaho area. So you've definitely paying attention to statistics on that. So let's just jump right into it. So show me what you got in your hand there. You showed it to me earlier, hot off the press.
Hot off the press. The actual Pfizer vaccine trial, the briefing that was submitted and that was used to discuss with the FDA in order to obtain the emergency use authorization for the Pfizer vaccine. You can go online and whatever your search engine is, and you can put in Pfizer BioNTech Covid19 vaccine, and then it's called briefing document, meeting date, December 10, 2020, right there.
Okay.
And you can follow along. And I encourage everybody that's interested, you don't have to be a doctor or a scientist or anything, and just go online and find it. It's public information. You can go online and find it. I actually just found the Moderna trial, public briefing report that they gave to the FDA that recently they got emergency use authorized. And I'm going to go through that later with Dr. Sorin, hopefully. But today we're talking about the Pfizer vaccine trial. Right. It's really awesome.
So let's just really quick, because I think there's some issues in the media of FDA approved versus emergency use authorization. Do you want to go over what the difference is?
Sure. I think it's very important to even just to start out, and I'm glad you pointed that out, start out at that level. It's a big deal. Because normally the FDA has a process that usually you have to do a study, and it may take several years of study to get data, placebo, to watch these two groups of people in your study, whatever you're doing. It takes several years usually, but because of an emergency, I believe in 2005, the federal government added a clause that you could approve something in a pandemic setting where you don't have 2 or 3 years to wait to get something on the market that could dramatically save lives or reduce hospitalizations or injuries or things like that. And so there's this other category of not FDA approved, but emergency use authorization from the FDA. And so those are two very different things.
So very clearly, this vaccine has been approved under the EUA, Emergency Use Authorization. It is not FDA approved. Those are two very different things. So
that is correct.
FDA approved requires,
because that won't happen until the trial is actually completed, and the completion date on this trial, I believe they said it is 24 months after the 2-month watch period, which is November 14, 2020 is when the data from this trial, from this submission ended. So it'll probably be November 2022 is when the trial will be complete. So how could something be FDA approved before it was complete? It's not, it's emergency use authorized.
Perfect. So I just want to make that clear because in the media, they're saying this is FDA approved. It is not. Some of the media reporters are claiming it's, but it's not. And there's a big difference. And as we go through this, I think people will find out why that difference is. So let's just start off by saying what are the conclusions? Just big picture overview. What are the conclusions? And then after that, I want to say what is the study not saying? So let's just go through. What is the study showing? What are their end results and what did it prove?
Well, the main purpose of this study, and they put it in their own words, the proposal to obtain the emergency use authorization from the FDA is they wanted to develop an immunization for the prevention of the COVID-19, which is a disease caused by the SARS-CoV-2 virus in individuals 16 years and older. That was their whole purpose of the study. That was the main crux of everything, and that's what they presented to the FDA to get emergency use authorization. And that very specific thing is an immunization to prevent COVID-19, which is a disease caused by SARS-CoV-2 virus in people 16 years and older.
Okay, so that's what they set out to prove, and they did show that. My understanding is that showed in the group that had the vaccine, there was 8 cases after the second dose of the trial, and in the other group, there was 100. In the placebo group, there was 162. So that's where they're showing their 90+% efficacy. Correct? Is that correct?
That's right, and that is exactly correct. And then now let's go to the definitions. You use the word cases, and so we should define what they called is a case. So how did they diagnose it? So like you said, their main, what they showed very clearly, they could claim, because they had enough numbers and enough data and enough time, that they could say, and it was like a 95% reduction of cases of COVID-19 in the vaccinated group versus the placebo group, the ones that didn't get the vaccine. And so the key thing is the case they define as you must have one or more symptoms of coronavirus infection, and then you must have a positive COVID-19 or a SARS-CoV-2 test result. They did nasal swab. So they did you had to have if you didn't have any symptoms of COVID, they were not testing you if you had no symptoms. You must have a symptom, and it could be fever, cough, short of breath, typical those COVID symptoms. And then they'll swab your nose. If it says COVID, boom, that's a case.
Okay, so that's a very important difference. So for them to, this is one of the first big points I want to bring out. So in the vaccine study, for you to be a case of COVID, you need to have at least one symptom and test positive for COVID, right? So now let's define just kind of a quick fun aside. Now, in the statistics we're seeing nationwide for COVID, what is the criteria that they're using for COVID?
Well, right now, there's a lot of leeway and there's a lot of wiggle room. You can actually, we're actually swabbing for COVID with nasal swabs, people that don't have symptoms, but maybe they were exposed at some point. Maybe they're concerned they might have it, or they need to go back to work, or maybe somebody's being admitted into the hospital or going to have a surgery, and then they'll swab. But they may not have COVID symptoms, and you can still swab.
So one big difference is we are testing healthy people, where normally for the influenza, you never test somebody healthy. You don't just somebody walks through the hospital, test them for influenza. So that's one, I think, difference people are going to see in statistics. Why the numbers are so high of COVID cases is because you're testing healthy people. You're basically testing anybody who walks through the door that gets admitted to the hospital, whether they're admitted for a gunshot wound or whether they're admitted for actual COVID type of, symptoms. So that's one big difference.
True.
And then
that is one major difference
Yeah. And then
Yeah, that
also,
is one major difference.
you're testing people to go back to work. Like if somebody was exposed to COVID and they want to go back to work and they're feeling totally fine, they got zero symptoms, you're also testing those people. So those people's numbers show up in the statistics because some of them do show up positive, even though they're asymptomatic, right? Whereas
Correct.
in the study,
Yeah, correct.
for you to be COVID positive, you had to have at least one symptom and a positive test. So it's more rigorous criteria.
Right. You need both. You need to have a symptom, and they have a list of symptoms: fever, new cough, new shortness of breath, chills, new muscle pain, new loss of taste or smell, sore throat, diarrhea, vomiting. One of those, a minimum, and then a positive test. And also so with the influenza, if you do a nasal swab for influenza, it uses the same type of test, a PCR nasal swab. Like you mentioned, we don't swab people for influenza unless they have symptoms of influenza, uh, and so that is a difference. And then with this one, you have to have a symptom and you swab. But if the swab came back negative, they didn't count them as a case. Even if you had all the classic symptoms of COVID, if your test wasn't positive, that wasn't a case of COVID-19.
Right, because you've mentioned that in the hospital, the doctors now have some leeway in defining COVID, because if somebody has all the symptoms and the doctor feels it's very likely to be COVID, it's still counted as a COVID, even though the test may be negative.
Yes.
All right.
Yep, you call it just it's suspected COVID, and we're treating suspected COVID, and we'll count that as a COVID patient because we're treating them.
So that's where you're seeing a major difference. And if we have time, we'll get into that, but that's where you're seeing much higher percentage-wise cases in the community than you saw in the study.
It could very well be. Yeah, it's possible.
So, all right. So we talked about, you just mentioned a little bit ago what the study showed. Let's talk a little about.
Sorry, that's my guard dog. Lincoln.
Let's talk about what the study did not show. So what are some conclusions we can't draw from this study?
Well, so because it is still emergency use authorized, they've only been monitoring the patients. About 90% of the patients that have had both doses of the vaccine have been monitored for at least 4 weeks. Only about 50%, just a little over 50% of the patients that have gotten the 2 doses of the vaccine have been monitored for 2 months. So this is very limited. 90% at 1 month we have data, and we have about half of the participants at 2 months of data. So you're going to be limited. And also it's only the total number of participants in the trial. There's a placebo arm that didn't get the vaccine, and then the vaccine arm. The total is just under 38,000. So there's about 19,000 people in each group. And so the numbers are small, the time is short, so you're going to be limited on what you can claim. And that's why the claim is confidently that there was a reduction, because there was 170 cases during this observation period of tracking, and 8 vaccine group and 162 in the placebo group. And they could confidently claim that it reduces the case number, the incidence rate of getting COVID-19. But what we couldn't say, unfortunately, with this study, because it's so early and small, is that it reduces death from COVID-19.
So how many people in the study died from COVID-19?
Well, I looked at that. That was as a physician or somebody that works in the hospital or in healthcare, when our hospitals are maxed out at capacity, the ICUs are full, the hospitals are full, and we're worried about we want to reduce hospital admissions and ICU admissions because we're running out of space. The first thing I went to was, number one is, did it prevent death? Did it save any lives in the vaccine group versus the placebo group? So you look how many people died of COVID in each group, and 0 people died in the vaccinated group. But unfortunately also, which is good, but 0 people died in the placebo group from COVID. So it wasn't enough, 38,000 participants wasn't enough in 2 months to have anybody die of COVID in either arm, either placebo or vaccine.
Okay, so I think that's a huge distinction. So one thing the study cannot claim is that, number one, it reduces deaths, because there were no deaths from COVID in these almost 40,000 people, 38,000 people, correct? Um,
That's
and then
correct.
secondly, I
So,
believe there was also, can you show that it decreased ICU admissions?
so that's another thing that I was very interested in is hospitalizations. And then in that ICU, the sickest of the sick, maybe people that need a ventilator, people that need a high flow oxygen, IV blood pressure medications, drips, antibiotics, things like that. ICU is a very limited space and highly sought after in terms of reserving it for the people that are very, very ill. And when you look at the numbers of ICU admissions in this study of about 38,000 people in the placebo and the vaccine arm, there were no admissions to the ICU in the vaccine arm, but there was only one admission to the ICU in the placebo arm. So 1 versus 0, it's just not enough data points to claim it reduced the admissions into the ICU, unfortunately. But that's why it's early on. It's not a lot of participants. As time goes on, you'll add more participants and you'll add more time, and you'll be able to track and get bigger numbers to be able to make that claim. You can't say one way or the other.
Right, because that's one of the things in studies is what are the chances that chance caused the one to be in that group and not the other group? Because there's only one, they can't really claim that.
And that was
Transmissibility.
ICU.
Yeah, did they look at transmissibility? Would this vaccine reduce the transmission of COVID?
That's a good question. I do want to point one more thing out on the hospitalization, that there was actually, in addition to one ICU patient in the placebo arm that didn't get the vaccine, there was, sorry.
It's okay, keep going, keep going. Keep going, Dr. Issa.
Okay, sorry about that. Grandfather clock. There was also, in addition to the one ICU admission, there was one hospitalized patient, but they weren't in the ICU, and that was also in the placebo arm. They didn't get the vaccine, and there was no hospitalizations or ICU in the vaccinated group. But once again, 1 versus 0, it's not enough to make a claim either way.
Okay, what about transmissibility? Like, does this vaccine stop the disease from spreading? Could they draw that conclusion from the study that was submitted to the FDA?
No, unfortunately, this study was not designed to detect if the vaccine or the immunization prevents someone who contracted the coronavirus from spreading it to other people. It's not designed that way. They're not looking for it. They might be able to make an additional design based off this group of populations going forward. But this study was designed specifically to reduce COVID-19 disease, to prevent someone from getting the disease or getting very sick from it, not designed to look to see if you can still spread it. We don't know.
So that's, I think, one of the major points I want to make from this is based on the study that was used to get emergency use authorization of the Pfizer COVID-19 vaccine. There is no data to show that it decreases transmissibility. There's no data to show that it decreases ICU admissions. There is no data to show that it reduces any sort of hospital admissions. And there's no data to show that it decreases death rate. That was not the point of the study. So there is zero evidence for that. The only thing they can show is that it did decrease the incidence of people who tested positive and had one symptom, correct?
That's correct. Yeah. And so I'll just clarify. You said it exactly correct. We cannot make any of those claims, although the study wasn't designed to ever show transmissibility. That's not something that if you wait long enough, they'll have an answer for in this one. That is different from the severe cases, which are hospitalizations, ICU, and death. Eventually, we should have enough data that over time, when the trial is over in a couple years, we should be able to prove one way or the other, make a claim on those, but not on transmissibility. They state very clearly this is not designed to ever detect that. So even in 2 years from now, this study will not help us with that. There has to be other studies. That's very important.
Yeah. So anyway, I think that's a very, very interesting. V- I think that's super interesting, at least to know what the data that they show. Because when you
Right.
hear on TV that this study is FDA approved, no, it's not FDA approved. It's gotten emergency use authorization, which it's going to take the full 2 years to get that FDA approval. So let's talk a little bit about some of the side effects that were noted. I just think those are kind of interesting to go through. So
Sure.
what were some of the side? Oh, by the way, in this group, I find it, let me actually share my screen with you here. Uh, so, so here we're on the Pfizer study, and let's see, we're on page 19 of the one on the internet. So again, there was a total of 6 deaths, and these are deaths from other
We're talking
causes.
about safety now.
So talking about safety, yep. So there was 2 deaths, and again, they were for other reasons. In one arm, and in the other arm, there's 4 deaths. So again, those are just deaths from random, people die. So it's very interesting to me that 6 people died just of random causes in the study,
Right.
but 0 people in this study died of COVID.
Right. These 6 people that died during the study, they didn't have COVID.
Right, exactly. So, and then one other thing, I think it was on page 78 of this study. Let me just see if I can quickly get to it. It actually shows you, let me see here. It actually shows you what the definition of severe, here it is. It shows you what the definition of severe COVID is, which I think is very interesting because the lowest point there is an O2 saturation of 93%. So that's how they're defining severe COVID.
Yes,
Correct?
that is correct. So they use the term, they didn't really tease out because there weren't any deaths from COVID. So they said there were cases that were reduced by 95%. So it was very effective in reducing symptomatic COVID cases by 95%. And then they had another category that they were watching is to see if it reduced severe cases of COVID. And so if you can find that,
Yeah, it's
I
right
think
here.
we're looking
So
right at it.
here's the criteria. So they're defining severe COVID as clinical signs, respiratory rate greater than 30, that's pretty bad. Heart rate 1/125, again, that's not normal. That's definitely significant of a severe problem. But this oxygen saturation less than 93% on room air,
What's that are equal to?
that's pretty common,
Yeah,
unfortunately.
that's equal to. So actually 93%, if you hit that 93%, it's important to point out when they differentiate as a case of COVID versus a quote severe case. A severe case of COVID could be somebody with a 93% oxygen and they have a cough, but they don't need any medications, they don't need oxygen, they're not admitted, they're going home without any treatment, all the way up to death. Those are both lumped into severe cases of COVID.
Yeah, so I'll show you the death thing here. Again, this is on page 78, now going to page 79, it's got death. So, ECMO and all these things that are super invasive, you're on death's door if you're getting to that point where you need ECMO. But it could be, the bar could be set as defined of severe COVID as having an O2 sat of 93%, which a lot of people with chronic illnesses like, obesity, chronic asthma, COPD,
Emphysema.
they probably cruise, that's their, they cruise at 93%. So I want to also show that part was interesting. Let's see, anything else? So let's talk about side effects here. What are some of the side effects that they saw from the vaccine?
Well, yeah, the adverse, I think they call them AEs or adverse
Effects, events.
If we can pull up that page.
Yeah, I've got it here. Let me share that with you. So here's the adverse effect. So again, this BNT16H2, basically this is the vaccine group, and the placebo group is on this other side. So again, you can see these are very close to equal. Cardiac, you got 14 on the vaccine group, 12 on the non-vaccine group. Let's see, gastrointestinal disorders, 8 on the vaccine group, 6 on the non-vaccine group. Let's see what else stands out. You know,
Right, and this is where you would look at, when you look at adverse effects, this is where they're trying to determine whether it's safe or not. Not whether it works, not whether it prevented COVID cases, but is it safe? They'll compare the vaccinated group with the placebo group on, you know, like you said, heart attack, stroke, allergic reaction, anaphylaxis, appendicitis, Bell's palsy, you know, all these different things. That's what they're going to compare and see, you know, was there similar bad outcomes or adverse effects in both groups? And then they can say it's safe if there wasn't any statistical difference.
It looks relatively similar. One interesting thing here is in the infectious, you looks like you have 7 appendicitis on one side, on the vaccine side, and 2 on the non-vaccine side. So again, I think they can't, those numbers are too small to really draw a conclusion, but it is.
Yeah, the only 2 that really stood out at me, and it's too small to claim whether it's related or not, was the appendicitis. Like you said, the vaccinated group had 7 and the placebo had 2. And then also, I think the Bell's palsy, I think there was 4 in the vaccinated group and 1 in the placebo group, but you can't say one way or the other. But they mentioned it, actually. They actually mentioned that there was more in those 2, and that they would continue to do surveillance on that as you get more volume, more numbers of participants and more time. They're going to see if that pans out or not. They may or may not.
Yeah. So let me just get this. So basically, in conclusion, I think it's fun. You actually read the whole study. I got through most of it because you encouraged me, and I did find those things interesting. But
I mean, it's kind of nerdy. I watched the part of the actual discussion when they were doing it in the panel, the FDA advisory panel, and the Pfizer, you know, scientists, and it was like, oh, you know, why don't I read it and see what I could find? I thought it was like, oh, this is really neat, you know, to look through myself. And I think everybody should go through and look at it. It is kind of boring, but if you're kind of nerdy, you might find it interesting.
yeah, and you can find it online again, like I did and like you did. So anyway, I thought that was pretty interesting. But to me, one of the major things that I got from this is that they did not show that it decreases the transmissibility. Again, you can infer that, you know, if it reduces the cases, maybe it would do that, but they didn't show that. They didn't have to show it because of kind of rushing it through under this emergency use. And again, they didn't show it decreased ICU deaths and didn't show it decreased hospital admissions, and there's no deaths. So speaking of deaths, just what I believe Kootenai Hospital, I think from some of the data I saw, they had about 665 admissions.
That's
now,
correct.
If
COVID admissions, yeah.
If you compare the rate of admission in the study, which was 7 people were admitted in the placebo group out of 19,000, again, that's a far lower number to have 7 out of 19,000 for the population, for there to be 665 people admitted to Kootenai Hospital, which I think is roughly, I'm pretty sure that's fairly accurate data. There would need to be 1.8 million people in the area. So, you know, again, if you do a ratio of 7 over 19,000 is equal to 665 over X, again, that number ends up being 1.8 something million people. So
yeah, I don't know how large of a catchment area that the
Kootenai Hospital has, but I'll tell you, it's not 1.8 million.
It's probably not. There may be a couple million people in Idaho.
Well, in all of Idaho, but most of which are in Boise. But anyway, I find that interesting too. And again,
it's probably because it's it's too small numbers. You know, that 19,000. Maybe they need to have, you know, instead of 38,000, they need to have 80,000 or 100,000 to get more the volume. But it is interesting that you'd have to have 1.8 million people to have that same level of that same number of admissions that they found in this study. And they had study locations all over the world. I mean, they had in Brazil, and they had in the US, and they had in Turkey, and in all sorts of countries. So I don't know if that played a role in the prevalence or the incidence rate versus one location. But anyway, it really stood out that there was only 7 admissions out of 19,000,
Yeah.
or yeah.
And here you go. That leads me into this other topic. Have we cured influenza and the flu? So this is statistics. I'm going to share this with you. This is straight from the CDC. Again, this comes from FluView on the CDC website here. What you're seeing here, this is the data from 2017, 2018. You can see the number of cases by week. And so you're seeing here, it's peaking around 4,500. That's in the 2017, 2018. If you look at 2018, 2019, looks like it was a better flu season. You see numbers around 3,500 at the peak here. If we look at 2019, 2020, again, you're seeing peaks here. Looks like 3,800. So now, are you ready? Drum roll, please.
I'm ready.
All right, so now we look at the 2020-21. Look at the numbers over here. The peak is 24. We're not talking 2,400. We're talking 24. So this is
24 cases of influenza.
Yeah, this is like more than 150 times reduced over what it was a year. So this is this is from the CDC. This is not even from who knows what, conspiracy website. This is straight from the CDC website. It's showing that the influenza has been drastically reduced.
This is FluView Interactive, cdc.gov, and there's 24 cases in 1 week as opposed to prior years, anywhere between 3,500 and more.
4,500.
What was
that? So I know one of the ER docs at Bonner General talked about how everybody's been so focused on COVID that they haven't really done as many of the flu tests. Although you said in some of the ERs you work with, because I know you work outside the Idaho area as well, that you've ordered a lot of flu tests. But I still think that's interesting statistics because the flu has magically almost disappeared. And
right. It's not even close. It's not like 33,500 every week, and now it's 2,800. It's 24.
Yeah,
and that's week after week after week. This flu season, it's mind-boggling. It's amazing. I'm worried. I don't know where it's going, or is it going to hit later, or is something going? But it is. I've never seen anything that dramatic of a reduction of 24 cases a week of flu versus 3,000 or 4,000 a week.
Well, and
mind-boggling.
It is mind-boggling, but it also may have to do with the way they're tracking statistics and the way they're labeling things. At least is my theory. But either way,
maybe the person that's tallying the flu cases is on vacation, and then we'll get all the flu cases all at once, and it'll all be like last year.
Well, anyway, I think that's kind of an interesting piece of info. And if you look at here, this is super fascinating too. Again, this is from the CDC website. If you look at influenza-associated pediatric mortality, which I think I have up here, this is super duper fascinating. So you look at the 2017-18, this is the number of influenza-associated pediatric deaths by week. So this is the number of pediatric cases that are dying of the flu. And so you look 27-18, it peaks around, looks like 16, 17, 15. If you look at the 2018, 2019, again, peaks look like around 8 cases. And again, you look for the season, there's a total 2017-18, there's 188 deaths. 2018-2019, 144 deaths. 2019-2020, you got 195 deaths. And again, drum roll, please. For the 2020-2021 season, there is 1 death. So
unbelievable.
We've had a reduction from say an average of 170 deaths a year for the previous 3 years to this year, 1 death. So again, I don't know if somebody smarter than me can explain that to me, but I do find that to be very interesting. So again, magically, one child has died of the flu according to CDC statistics, in the 2020-2021 season. Again, we're still early in the season, but again, you can see the numbers.
Well, and look at the numbers of cases in the prior years. Isn't it in the thousands?
No, these are just deaths. This is not cases. Yeah, you're right. I wonder if they have got.
No, no, no. It says positive cases on the left-hand side. Look up at the left-hand side all the way to the left. It's like 3,000, 4,000, 5,000 cases on the left, and then at the bottom it's deaths. You're right, for in the whole season. But look at the cases.
Yeah, I'm not. I'm not seeing that. Is this? No, that's a different statistic there. But oh, I see. I see. Maybe you're seeing a different screen. But either
Anyway,
way,
either way,
uh,
either way, it went from about 180 deaths, pediatric influenza deaths, to one so far. But you know, there's still a few more months of influenza season.
but even if you compare it to date,
That's true.
there's a drastic reduction. So
Date to date, it's a dramatic. It's a
yeah.
99% reduction in deaths.
Yeah, which is, again, just tells you there's something going on with the way they're tracking statistics, because I don't think we've magically cured influenza. It just, something's going on with the way they're tracking it. Couple other interesting things, just want to have, just go over with you, because I know one of the things that people have said is, here we are. So let's just look at the total number of deaths. I want to share this data. And again, this may just be kind of interesting to go through, but I just want to share this with the listeners, with the viewers. Again, this is the latest data from the CDC website. This is data in Tableau. This is the weekly deaths from all causes. And so we see data all the way into like 2016 here. I'm sorry, January of 2017. So you kind of see this is total all deaths in the United States. So you kind of see these peaks that are kind of seasonal, and you definitely see an increase in deaths this year. So, you know, I think we can say that, there it is. I think we can say that, you know, I mean, this pandemic is real. There is definitely an increase in the number of deaths in the United States. But if we kind of separate that out and we start looking at some of the different states, let's look at California. Again, when you look at California, overall, you see an increased number of deaths, but the peak was still higher in 2018 in California when you look at this weekly number of deaths. So again, you're seeing significantly higher peaks in, looks like January of 2018 versus, let's find, you know, January of 2020 and December of 2020. You were still far lower in those cases. So that's California. Let's just look at Idaho. And again, in Idaho, you're definitely seeing an increase here in the overall deaths. And then let's look at, you know, Washington, I think was an interesting one. You look at Washington State. And again, if you look at this data, looks like 2016, 2017 was higher. So that's also an interesting point. This is all cause mortality. So it looks like more people died in the state of Washington, looks like in that 2017 time period, at least looking at the weekly numbers. Oregon, I think, looks very similar. Again, so if you look at this data, maybe there's a slight increase, but it's not as dramatic as you would think. The places, you know, again, like I pointed out in my previous video, New York City had a huge spike, but if you looked, it's really, really decreased the total death rate here. Whereas this peak here and looks like November 28th of 2020, you know, looks like it's actually lower than the peak on January 13th of 2018. So again, we saw this huge spike early on this season, but now we're kind of seeing it kind of be closer to the usual numbers, even in New York. Was there any other state you want to look at? You mentioned South Dakota, was it?
South Dakota is interesting because their governor, they've never had a stay at home or a lockdown or a statewide mandate of any kind, whether it's mask or social distance.
So,
Just recent, yeah, just recently in the last month or so, some of this, like the big city, maybe Sioux Falls or something, I think they put their own mask requirement, but it's never been statewide.
so in that state, you are definitely seeing an increase in the number of deaths that's happened recently, but you definitely didn't see one early on. We're seeing a spike now, which is super interesting to me because the other cities seem like they've had, the spike early on and now everything's kind of normalized. And then just in the last few minutes, if you look at our data in Bonner County, I think it's pretty interesting. So this is Bonner County data from 12/16 of 2020. It shows that in Bonner County, there's 424 active cases with a total of 1,500 confirmed positive cases thus far. So that's interesting to me that 1,500 people have confirmed positive cases in Bonner County. And again, I don't know, I know there's a statistic from the CDC saying there's 10 times more people that have had COVID than have gotten tested for it, because plenty of people are very mildly asymptomatic. I know I've met people in that category too, where people say, man, it was like a minor cold. And I've met people that have been like, man, this thing really beat me up. But still, a lot of those people with the minor symptoms are not getting tested. So
that's right.
So anyway, I think those are interesting statistics to look at, and hopefully maybe we're even starting to approach, at least getting part way towards the herd immunity. So that would be a positive thing. It means if 1,500 people hopefully have a reduced likelihood of transmitting disease. So when you get enough people, those, and it doesn't bounce off of them anymore, it just goes away.
Right. That brings up something. There was something else interesting in the Pfizer trial. Initially, they excluded anybody that had a history of having COVID in the first several phases, but in the final phase, they stopped excluding people. So they didn't go out and look for people that had prior COVID infection, but they allowed them to participate, and they ended up with about 500 patients that had COVID, and then 500 in each arm. 500 patients that had prior infection of COVID in placebo, and 500 that had a prior infection of COVID in the vaccine arm. And what's interesting is there were, out of 500 and something, it was a 500 and something, one person got it again out of 500. And so that was, 1 out of 540 or whatever it is. It's, if you compare that to the rate of 162 out of 19,000, you see, 162 divided by 19,000 versus 1 divided by 500, and I think it was 526. It's about an 80% reduction in likelihood of getting COVID again, but it's such small numbers, you can't claim it. It's not factual, but if you could extrapolate 1 out of 500 to 162 out of that never had it before that got COVID out of 19,000, it's very interesting. But it's obviously too small. They weren't able to make any comments about the people with prior infections because it's just only 500 in each group, somewhere in there. But that will be also very interesting to track as they get more participants that have had COVID before, is how many of them, what percentage of people that have had prior COVID get symptoms and test positive again. That's something to follow.
Yeah, really fascinating. Interesting you mentioned that. And then, hey, last thing I want to show is just, let me share my screen with you one more time here. So this is data from Our World in Data. So this data right here just kind of highlights the different countries, and this one right here is confirmed deaths. So if we look at the confirmed deaths, you can kind of see a trend here. And again, we saw an early huge spike here, and from March 1 to April, and then we saw a significant reduction. And then here this fall, we're seeing another huge spike. So it is interesting as you're looking at this data, like Italy looks like it's had one of the worst spikes, and they're probably one of the most locked down countries. You know, the United States is here. And again, you know, not quite as bad as Italy, but definitely having a spike. We look at Germany. Again, Germany has been very locked down, and so they're having an increase. Sweden, that has not locked down. This is very interesting to me. If you compare Germany and Sweden, you know, Sweden and Germany look almost identical, other than Sweden having a bigger spike early on. Again, United Kingdom looks very similar to Sweden. United States is not that different. You know, Spain, not that different. Canada, again, they've had, for some reason, a lower case fatality. Again, this is a 7-day rolling average for, you know, cases per million. But again, it's fairly interesting data to me. Again, as you analyze the efficacy of lockdowns and what this pandemic is doing, it's just interesting to look at that data.
Yeah, and just so for the reference, the source for that was, what was it called? Our World in Data.
Data.org.
Yeah, ourworldindata.org. Take a look at that if you guys have a chance. It's very powerful. It's very the graphs are very nicely done, and you can look up all sorts of different data points.
Well, Dr. Issa, it's fun. Thank you for reading that 92 pages of that Pfizer study.
You're welcome.
I really appreciate people like you that actually get into the weeds and read those things. And thank you so much for being willing to spend a little time with us. And
Thanks for having me.
That
was fun. Always a pleasure.
Thank you so much. All right.
Bye-bye.
Bye-bye.